When I was a kid, the disaster we worried about most was a nuclear war. That's why we had a barrel like this down in our basement, filled with cans of food and water. When the nuclear attack came, we were supposed to go downstairs, hunker down, and eat out of that barrel. Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now, part of the reason for this is that we have invested a huge amount in nuclear deterrence, but we've actually invested very little in a system to stop an epidemic. We're not ready for the next epidemic. Let's look at Ebola. I'm sure all of you read about it in the newspaper. Lots of tough challenges. I followed it carefully through the case analysis tools we use to track polio eradication. And as you look at what went on, the problem wasn't that there was a system that didn't work well enough. The problem was that we didn't have a system at all. There's three reasons why it didn't spread more. The first is there was a lot of heroic work by the health workers. They found the people and they prevented more infections. The second is the nature of the virus. Ebola does not spread through the air. And by the time you're contagious, most people are so sick that they're bedridden. Third, it didn't get into many urban areas, and that was just luck. If it had gotten into a lot more urban areas, the case numbers would have been much larger. So next time, we might not be so lucky. You can have a virus where people feel well enough while they're infectious that they get on a plane or they go to a market. The source of the virus could be a natural epidemic like Ebola, or it could be bioterrorism. And so there are things that would literally make things 1,000 times worse. In fact, let's look at a model of a virus spread through the air like the Spanish flu back in 1918. So here's what would happen. It would spread throughout the world very, very quickly. And you can see there's over 30 million people die from that epidemic. So this is a serious problem. We should be concerned. But in fact, we can build a really good response system. We have the benefits of all the science and technology that we talk about here. We've got cell phones to get information from the public and get information out to them. We have satellite maps where we can see where people are and where they're moving. We have advances in biology that should dramatically change the turnaround time to look at a pathogen and be able to make drugs and vaccines that fit for that pathogen. So we can have tools, but those tools need to be put into an overall global health system, and we need preparedness. The best lessons, I think, on how to get prepared are, again, what we do for war. For soldiers, we have full-time waiting to go. We have reserves that can scale us up to large numbers. NATO has a mobile unit that can deploy very rapidly. NATO does a lot of war games to check, are people well-trained? Do they understand about fuel and logistics and the same radio frequencies? So they are absolutely ready to go. So those are the kinds of things we need to deal with an epidemic. What are the key pieces? First is we need strong health systems in poor countries. That's where mothers can give birth safely, kids can get all their vaccines, but also where we'll see the outbreak very early on. We need a medical reserve corps, lots of people who've got the training and background who are ready to go with the expertise. And then we need to pair those medical people with the military, taking advantage of the military's ability to move fast, do logistics, and secure areas. We need to do simulations, germ games, not war games, so that we see where the holes are. The last time a germ game was done in the United States was back in 2001, and it didn't go so well. So far, the score is germs 1, people 0. Finally, we need lots of advanced R&D in areas of vaccines and diagnostics. There are some big breakthroughs, like adeno-associated virus, that could work very, very quickly. Now, I don't have an exact budget for what this would cost, but I'm quite sure it's very modest compared to the potential harm. The World Bank estimates that if we have a worldwide flu epidemic, global wealth will go down by over $3 trillion, and we'd have millions and millions of deaths. These investments offer significant benefits beyond just being ready for the epidemic. The primary health care, the R&D, those things would reduce global health equity and make the world more just as well as more safe. So I think this should absolutely be a priority.
This looks like a very mild disease, like a common cold, in the majority of people. There are certain people who get infected and have very serious illness. Among them are health workers. It's a very serious infection in them as they get a higher dose than normal people, and at the same time they have no immunity. So in the general population, it's likely that the dose of virus that you receive when you are infected is much less than the dose that a health worker would receive, health workers having more serious infections. So your infection would be less serious, hopefully. So that leaves the elderly and those with comorbidities to really be the ones that we have to make sure are taken care of in hospitals. Well, the most concerned are people who are, first of all, in developing countries and who don't have access to good medical care and may not have access at all to a hospital should an epidemic occur in their country. Those people would be at great risk, especially the elderly. Elderly in all populations are at risk, but especially those who can't get to oxygen. In industrialized countries, it's the very elderly who have comorbidities, who have diabetes, who have other diseases, who are at risk. The general population doesn't appear to be at great risk. First of all, pulmonary disease existing as a comorbidity is also important. In general, the elderly are at greater risk, especially those over 70, because their immune systems are not as effective as they might have once been, and they're more susceptible to infections. In addition, in some instances in China, there's been a co-infection with influenza, and at the same time, there have been some bacterial superinfections on the pneumonias that are occurring. The Center for Disease Control in Atlanta keeps track and has updates on a regular basis on its website. Also, the World Health Organization in Geneva, which is coordinating many of the activities going on internationally, also has a website with daily updates. It's our responsibility to get that information as individuals so we understand and can make sure that we can contribute in our own way to prevention of major spread. It's the same problem with all new infections. This is an infection that's come into humans who have never been exposed to this virus before. They don't have any antibody protection, and it's not clear whether their immune system can handle this virus or not. This is a virus that usually finds itself in bats or in other animals, and all of a sudden it's in humans. And humans just don't have experience with this virus. But gradually we are beginning to learn a lot, as we did with SARS. And you know, there are certainly a larger number of deaths than there were with SARS, but when you divide that by a denominator of persons who are infected, there are many, many more persons infected than there were with SARS. The case fatality ratio, that is the ratio of deaths to the numbers of cases in SARS, was about 10%. With the current coronavirus, COVID-19, is 2% or probably less. So it's a much less virulent virus, but it's still a virus that causes mortality, and that's what we don't want entering human populations. It's clearly understood that airports or any land borders cannot prevent a disease from entering. People in the incubation period can cross that border, can enter countries, and can then infect others when they become sick. So borders are not a means of preventing infection from entering a country by checking temperatures. Borders are important because you can provide to people arriving from areas that might be at risk of having had infection, providing them with an understanding, either a printed understanding or a verbal understanding, of what the signs and symptoms are of this infection and what they should do if they feel that they might be infected. Vaccines are under development right now. There's a lot of research going on. That research requires first that the vaccine be developed, then that it be studied for safety and effectiveness in animals who are challenged with the virus after they're vaccinated, and then it must go into human studies. The animal studies have not yet begun, but will soon begin for certain vaccines. And it's thought that by the end of the year or early next year, there may be some candidate vaccines that can then be studied for licensing by regulatory agencies. So we're talking about at least a year until there's vaccine available that can be used in many populations. That's clear. We know how it transmits. We don't know how easily it transmits in humans, in communities or in unenclosed areas. We know, for example, that in the enclosed area of a cruise ship, it spread very easily. We need to better understand how it will spread once it gets into more open areas where people are exposed to people who might be sick. A major problem in the world today is that we look at outbreaks in developing countries as something that we need to go and stop. So when there's an outbreak of Ebola, we think, how can we go and stop this outbreak in the country? We don't think about how can we help that country strengthen its capacities so that it can detect and respond to infections. So we haven't invested enough in helping countries develop their core capacity in public health. What we've done is invested in many mechanisms globally, which can provide support to other countries to go and help stop outbreaks. But we want to see a world where every country can do its best to stop its own outbreaks. Today, there are over 7 billion people. And when those people come into the world, they demand more food, they demand a whole series of things, and they live closer together. In fact, we're an urban world where people live in urban areas. And at the same time, we're growing more animals, and those animals are contributing food to humans as well. So what we see is that animal-human interface is becoming closer and closer together. And this intensive agriculture of animals and this intensive increase in human populations living together on the same planet is really a melting pot where outbreaks can occur and do occur. We will eventually have more and more of these outbreaks. So an emerging infection today is just a warning of what will happen in the future. We have to make sure that technical collaboration in the world is there to work together to make sure that we can understand these outbreaks when they occur and rapidly provide the information necessary to control them.
Is by then, this virus, well known now as Ebola, had spread too far. It had already outstripped what was one of the largest responses that had been mounted so far to an Ebola outbreak. By the middle of the year, not just Guinea, but now Sierra Leone and Liberia were also infected. And the virus was spreading geographically, the numbers were increasing. And at this time, not only were hundreds of people infected and dying of the disease, but as importantly, the frontline responders, the people who had gone to try and help, the healthcare workers, the other responders, were also sick and dying by the dozens. The presidents of these countries recognized the emergencies. They met right around that time. They agreed on common action, and they put together an emergency joint operations center in Conakry to try and work together to finish this disease and get it stopped, to implement the strategies we talked about. But what happened then was something we had never seen before with Ebola. What happened then was the virus, or someone sick with the virus, boarded an airplane, flew to another country, and for the first time, we saw in another distant country the virus pop up again. And this time it was in Nigeria, in the teeming metropolis of Lagos, 21 million people. Now the virus was in that environment. And as you can anticipate, there was international alarm, international concern on a scale that we hadn't seen in recent years caused by a disease like this. The World Health Organization immediately called together an expert panel, looked at the situation, declared an international emergency. And in doing so, the expectation would be that there'd be a huge outpouring of international assistance to help these countries which were in so much trouble and concern at that time. But what we saw was something very different. There was some great response. A number of countries came to assist, many NGOs and others, as you know. But at the same time, the opposite happened in many places. Alarm escalated, and very soon these countries found themselves not receiving the support they needed, but increasingly isolated. What we saw was commercial airlines started flying into these countries, and people who hadn't even been exposed to the virus were no longer allowed to travel. This caused not only problems, obviously, for the countries themselves, but also for the response. Those organizations that were trying to bring people in to try and help and respond to the outbreak, they could not get people on airplanes, they couldn't get them into the countries to be able to respond. And in that situation, ladies and gentlemen, a virus like Ebola takes advantage. And what we saw then was something also we hadn't seen before. Not only did this virus continue in the places where it had already become infected, but then it started to escalate, and we saw the case numbers that you see here, something we'd never seen before on such a scale, an exponential increase of Ebola cases, not just in these countries or the areas already infected in these countries, but also spreading further and deeper into these countries. Ladies and gentlemen, this was one of the most concerning international emergencies in public health we have ever seen. And what happened in these countries then, many of you saw, again, on the televisions, read about in the newspapers. We saw the health system start to collapse under the weight of this epidemic. We saw the schools begin to close. Markets no longer functioned the way that they should in these countries. We saw the misinformation, the misperceptions started to spread even faster through the communities, which became even more alarmed about the situation. They started to recoil from those people that you saw in those spacesuits, as they call them, who had come to help them. And then the situation deteriorated even further. The countries had to declare a state of emergency, large populations needed to be quarantined in some areas, and then riots broke out. It was a very terrifying situation. And the world, many people began to ask, can we ever stop Ebola when it starts to spread like this? And they started to ask, how well do we really know this virus? The reality is we don't know Ebola extremely well. It's a relatively modern disease in terms of what we know about it. We've known the disease only for 40 years, since it first popped up in Central Africa in 1970.
Ahora me gustaría que presten atención a algo. Las personas que están vacunadas no solo se están protegiendo a sí mismas, sino que al bloquear la diseminación de la enfermedad dentro de la comunidad, están indirectamente protegiendo a personas de esta comunidad que no están vacunadas. Crean como una especie de escudo protector que al hacer que no entren en contacto con la enfermedad, estas personas queden protegidas. Este efecto indirecto de protección de las personas no vacunadas en una comunidad por el solo hecho de estar rodeadas de personas vacunadas se llama inmunidad colectiva. Muchas personas en la comunidad dependen casi exclusivamente de esta inmunidad colectiva para protegerse de las enfermedades. Estas personas no son hipotéticos en una animación. Esas personas son nuestros sobrinos, nuestros hijos, que tal vez son muy chiquititos como para haber recibido sus primeras vacunas. Son nuestros padres, nuestros hermanos, nuestros conocidos, que tal vez tienen alguna enfermedad o están recibiendo alguna medicación que les disminuye las defensas. También son aquellas personas que son alérgicas a alguna determinada vacuna. Incluso podemos ser cada uno de nosotros. Si sí nos vacunamos, pero en nosotros la vacuna no generó el efecto esperado, porque no todas las vacunas son siempre 100% efectivas. Todas estas personas dependen casi exclusivamente de la inmunidad colectiva para protegerse de las enfermedades. Ahora, para alcanzar este efecto de la inmunidad colectiva, se necesita que un gran porcentaje de la población esté vacunado. Este porcentaje se llama umbral. Este umbral depende de muchas variables. Depende de las características del germen, de las características de la respuesta inmune que genera la vacuna. Pero todas tienen algo en común, que si el porcentaje de la población en una comunidad está vacunado, es por debajo de este número umbral, la enfermedad se puede empezar a diseminar más libremente y se puede generar un brote de esa enfermedad en la comunidad. Incluso enfermedades que hasta ese momento estaban controladas pueden volver a aparecer. Esto no es solo una teoría, esto pasó y pasa.